Imagine your immune system as an elite, heavily armed emergency response team.
Right, like a microscopic SWAT team.
That's exactly. When a heart attack strikes, a massive alarm goes off. They rush into the affected muscle to, save the day.
They break down doors, they clear out the dead tissue, they secure the perimeter. It's incredibly chaotic.
Right, but it's totally necessary for survival.
Yeah.
But here's the question for you listening today. What happens when that same elite team just, refuses to leave?
Yeah, what happens when, instead of packing up their gear and going home, they actually start demolishing the healthy neighborhood around them?
You end up with a heart that survives the initial crisis, but then slowly destroys itself from the inside out.
It is a devastating scenario.
Yeah.
And it's the exact biological reality playing out in millions of human hearts right now.
And the scale of this problem is just staggering. Heart failure affects over 56 million people globally.
It's massive.
And by 2030, that number is projected to skyrocket by 46%. But here is the truly sobering statistic. Even with all our modern medicine, the beta blockers, the ACE inhibitors, the surgeries, if you get a diagnosis of heart failure today, your 5-year survival rate is still less than 50%.
Which is wild, right? Mm-hmm. That statistic points to a fundamental gap in our medical arsenal. I mean, we've become incredibly proficient at keeping people alive in the immediate aftermath of a heart attack.
We can clear the blockages.
Right. We stabilize the rhythm. Where we are failing, though, is in stopping the progressive long-term damage that follows.
And that damage is driven by a paradox, isn't it?
Exactly. In the acute phase of an injury, inflammation is cytoprotective. You absolutely need those immune cells to clear the debris.
Otherwise, you just have necrotic tissue sitting there.
Precisely. But when that inflammatory response becomes dysregulated and just refuses to turn off, it triggers what we call pathological cardiac remodeling.
I always visualize that remodeling as the heart essentially turning to stone.
That's a great way to picture it.
The continuous inflammation forces the heart to lay down this interstitial fibrosis. It's this dense, stiff scar tissue that just completely ruins the flexibility of the heart muscle.
Right. It can no longer expand and contract efficiently to pump blood.
And our current solutions for this runaway inflammation are just incredibly blunt instruments.
They really are.
We use systemic drugs, things like colchicine or monoclonal antibodies like canakinumab. They lower inflammation in the heart, but they act like giant wet blankets over your entire body.
It leave you completely vulnerable. I mean, it's the biological equivalent of disabling the security systems for an entire city just to stop a noise complaint in one specific building.
You might solve the local issue, but you invite 100 new, potentially lethal infections.
Exactly, which sets the stage perfectly for the breakthrough we're exploring today in this deep dive.
Yes, we are pulling apart an April 2026 paper published in the journal Nature. It's titled Engineered Immunosuppressive Dendritic Cells Protect Against Cardiac Remodeling.
And the mission of this deep dive is to really understand how these researchers didn't just look for a new blanket drug.
Right. They engineered a microscopic, highly targeted peacekeeper, a cell designed to stop the immune system from permanently scarring the heart, but without shutting down your body's overall defense grid.
To pull off something that precise, you need an incredibly sophisticated delivery vehicle. And the researchers chose dendritic cells, or DCs.
Let's break that down for the listener. What exactly makes a dendritic cell the right vehicle?
Well, dendritic cells get their name from their shape. They have these long, branching arms that just constantly sample their environment.
Like little antennas?
Exactly. They are the ultimate orchestrators of your immune system. They sit at the exact nexus of your innate immunity, which is the fast, blunt first responder response, and your adaptive immunity.
The highly specific, learned response of your T cells.
You got it. There's essentially the intelligence officers. They pick up a piece of debris, show it to the T cells, and say, hey, attack this.
But the body also naturally produces a specific subtype, right? The tolerogenic dendritic cells.
Yes. And their entire job is the exact opposite. They present debris and say, stand down, this is friendly.
So in theory, those tolerogenic DCs should be exactly what a healing heart needs.
In theory, yes. The hurdle is that they are incredibly fragile.
Oh, really?
Yeah. In a highly inflamed, toxic environment like a heart that just suffered a massive infarction, these natural peacekeepers lose their stability. They essentially forget their identity in all the chaos and just join the riot.
Oh, wow. So they become part of the problem.
Exactly. And even worse, they're terrible at navigating through the bloodstream to find the damaged myocardium in the first place.
So the researchers had to give them a reinforced identity and basically a highly specific GPS.
That's the engineering part. They engineered what they call iCDCs. That stands for immunosuppressive and fibrosis-targeted dendritic cells.
And the targeting mechanism is just a stroke of genius. They aimed for something called FAP.
Fibroblast activation protein. Let's break down why that is such a brilliant target for you listening. After a heart injury, the local fibroblasts, the cells responsible for laying down structural collagen, get hyperactivated.
They go into overdrive trying to patch the hole in the heart wall.
Right. And when they do that, they start expressing FAP on their surface. Now, FAP is barely present in healthy tissue.
It's like a signal flare that only goes up when there's damage.
Exactly. So the researchers genetically equipped their dendritic cells with the FAP SCFV.
Okay, let me pause on that acronym, because SCFV sounds super dense, but it's actually a fascinating piece of engineering.
It really is.
It stands for a single-chain variable fragment. So think of a standard antibody as a big Y shape.
Right, the classic Y.
The researchers basically chopped off the entire stem of the Y and just kept the sticky tips at the top. And they attached those sticky tips to the dendritic cell.
And why do they do that? Because the stem of an antibody is what usually triggers other immune cells to attack.
Ah, I see.
By just using the tips, it becomes a stealth homing beacon. It turns FAP into a highly specific molecular ZIP code for the damaged heart.
That molecular ZIP code ensures the iCDCs flow through the bloodstream and park exclusively next to the hyperactive fibroblasts.
Exactly.
But I have to admit, when I first read about this targeting mechanism, my immediate thought was a lot more, well, violent.
Oh, so?
Well, if fibroblast activation protein is the homing beacon, and these activated fibroblasts are the exact cells laying down all this terrible scar tissue, why are we bothering to negotiate with them?
That's a fair question.
Why not just use that same ZIP code to send in a genetically engineered CAR T cell to just assassinate the fibroblasts directly?
It's a really tempting line of logic. And honestly, it's a path other research teams have actively pursued.
But there's a catch.
A huge one. We have to consider the physical architecture of the human heart. The fibroblasts are deeply integrated into the physical wall of a muscle that beats 100,000 times a day.
And it handles immense fluid pressure.
Right. If you send in an assassin cell to induce abrupt, widespread cell death of those structural fibroblasts, you risk physically rupturing the heart wall.
You could literally cause the heart to burst.
Exactly. Furthermore, massive cell death creates a secondary wave of intense inflammation, which is the exact fire we are trying to put out here. The goal with iCDCs isn't cytolytic warfare. It's diplomacy.
Okay, let's do a quick mini recap for you listening to make sure we've got the pieces on the board so far.
Good idea.
Bullet 1. Heart failure is a runaway train of inflammation and fibrosis. Bullet 2. Systemic drugs shut down the whole body, which is just too dangerous.
Right.
Bullet 3. So scientists engineered these stealth iCDCs using FAP as a localized ZIP code to send them directly to the heart's activated fibroblasts, specifically avoiding the urge to just violently destroy those structural cells.
Perfect summary.
But getting to the right ZIP code is impressive, sure. It's only half the battle, though. You have to actually change the environment once you arrive. So what exactly is inside this cell's diplomatic briefcase?
The researchers engineered these iCDCs to constitutively express 3 distinct immunomodulatory molecules.
Okay, what are they?
They are permanently wired to pump out CTLA, 4-Ig, PD-L1, and IL-10.
When I was looking at the mechanisms for these 3, I couldn't help but picture a highly coordinated 3-step de-escalation protocol for, like, a chaotic bar fight.
I love that analogy. Let's map it out.
Okay, so step 1 is CTLA-4-Ig. I see this as the bouncer at the door of the club.
That is a highly accurate way to frame it. To understand the bouncer, you have to understand how T cells activate.
Right.
A naive T cell floating by needs 2 signals to enter the fight. It needs to see the specific antigen, and it needs a co-stimulatory handshake, usually through a receptor called CD28.
Okay, so it needs a reason to fight and a buddy to shake hands and agree to fight.
Exactly. Now, CTLA-4-Ig physically binds to those handshake molecules on the surrounding cells with massive affinity. It basically blocks the door.
So if a naive T cell comes by, it can't get that secondary handshake.
Right. It is fundamentally prevented from getting angry in the first place.
Okay, so the bouncer keeps the fresh fighters out on the sidewalk. But what about the T cells that are already inside the club, you know, throwing bottles and smashing tables?
That requires step 2, PD-L1. This acts like a specialized crisis negotiator.
Because the bouncer can't calm down someone who's already swinging.
Exactly. CTLA-4 cannot calm down a T cell that is already fully activated, but PD-L1 engages with a receptor called PD-1, which is highly expressed on angry activated T cells.
And what happens when they connect?
When PD-L1 connects with that receptor, it sends an inhibitory signal straight into the T cell's nucleus. It essentially talks them down from the ledge, forcing them to power down and go into a state of exhaustion or tolerance.
Wow. Okay, so we have the bouncer and the negotiator, and then we have step 3, IL-10.
Yes, the third tool.
Now, this isn't a targeted cell-to-cell interaction like the other two, right? I view this as the soothing background music being pumped into the entire room.
That's exactly what it is. IL-10 is a broad, incredibly potent anti-inflammatory cytokine.
It just bathes the local tissue in these chemical signals that promote tissue repair and suppress all the angry inflammatory cytokines.
The bouncer, the negotiator, and the soothing atmosphere. But here's what makes this Nature paper so compelling. It's a concept they call non-redundancy.
Non-redundancy. What does that mean in this context?
It means the researchers didn't just, guess that these three would work well together. They ran rigorous knockout experiments.
Was testing them one by one.
Exactly. They engineered versions of the iCDC, missing just the CTLA-4, or missing just the PD-L1, or missing just the IL-10.
And what happened when they did that?
The entire system collapsed. Blocking any single one of those three factors completely ruined the iCDC's ability to induce regulatory T cells, or TREGs.
And inducing TREGs is the ultimate endgame here, isn't it?
Absolutely. Regulatory T cells are the body's natural long-term peacekeepers. Once you have a critical mass of TREGs in the tissue, they take over the job of suppressing inflammation permanently.
But to create them, you mathematically need all three tools, CTLA-4, PD-L1, and IL-10 firing simultaneously.
Because of this specific triple payload, the engineered iCDCs actually practice what they preach. Their own cellular phenotype radically shifts.
Meaning they don't look aggressive themselves.
Right. The researchers measured a drastic reduction in the iCDC's internal aggression markers.
Let's decode those markers for the listener because the paper heavily relies on them. They mention drops in CD80, CD86, and MHC2.
Yeah, think of MHC2 as a cellular display window where the cell holds up pieces of debris to alarm the passing immune system.
Okay, the display window and the others.
CD80 and CD86 are like the flashing neon signs pointing at that window. The iCDCs completely pull down the neon signs and board up the display window.
So they just look totally harmless.
Exactly. And at the same time, they massively ramp up a marker called TIM3 that acts like a giant do not disturb sign to the surrounding tissue. They just project absolute calm.
Okay, time for our second mini recap. So bullet 1, the engineered cell carries a triple payload, a bouncer, a negotiator, and soothing signals. Bullet 2, CTLA-4 stops new T cells, PD-L1 calms the active ones, and IL-10 shifts the environment toward healing.
Yep.
And bullet 3, all three must work in perfect harmony to generate the regulatory T cells that lock in the peace treaty. It's an incredibly elegant machine.
It really is beautifully designed.
But, biology isn't just about having the right machine. It's heavily dictated by timing. If you inject these perfect cells too early or too late, do they actually do any good?
That's the critical question, and timing was a major focus of the study. Remember that ZIP code we talked about? FAP expression on the fibroblasts?
Yeah, the signal flare.
Well, it is not a permanent static fixture in the heart. The researchers mapped the spatiotemporal dynamics of FAP in their mouse models.
Okay, so they tracked when it appears.
Exactly. They discovered that FAP expression progressively ramps up in the infarcted area, the dead tissue, and the surrounding border zones, starting around day 3 after the heart attack.
And when does it peak?
It peaks around day 14.
Okay, so they set up this brilliant Goldilocks test based on that timeline. They took 1.5 million of these iCDCs and injected them into mice on day 1, day 3, and day 7 post-injury.
And the data clearly crowned day 3 as the undisputed winner.
Which makes total logical sense if you visualize the biology. If you inject on day 1, well, there's no FAP, ZIP code yet. The fibroblasts haven't upregulated the protein.
Right. The beacon is totally dark. So the iCDCs have nowhere to dock and they just washed out of the system.
Conversely, if you inject on day 7, the homing beacon is blazing bright, but the concrete of the scar tissue is already drying.
That's a great way to put it. The fibroblasts have already laid down so much dense extracellular matrix that the physical damage to the heart's pumping capacity is just locked in.
So day 3 is the biological sweet spot. The beacon is visible, but the tissue is still malleable enough to be rescued.
Exactly. And the efficacy data they gathered at that day 3 intervention point is frankly staggering. And I really appreciate that they didn't just test this in a standard myocardial infarction model. Yeah.
Right, where they permanently ligate an artery to simulate a classic heart attack. They pushed it further.
They did. They utilized an ischemia reperfusion model where they tie off the artery and then open it back up.
So that simulates the massive wave of oxidative stress and inflammation that happens when a human patient gets a stent put in.
Right. And they even used a transverse aortic constriction model, or TAC, that involves physically banding the aorta to simulate severe high blood pressure and chronic pressure overload on the heart.
Demonstrating that this therapy isn't just a one-trick pony for acute heart attacks. It actively protects against the slow burn damage of chronic stress, too.
Absolutely. And across all of these diverse models, the mice treated with iCDCs on day 3 showed vastly improved ejection fraction and fractional shortening.
Meaning the physical squeezing mechanics of the heart were preserved. They could still pump effectively.
Yes. And at the molecular level, the physical scarring was actually halted. They measured massive drops in key fibrotic markers like fibronectin, periostin, and alpha SMA.
So the collagen networks simply stopped expanding.
They did.
But I want to dig into how the heart is actually getting better on a cellular level, because it is way more complex than just suppressing T cells.
It is. The authors described the effects of the iCDCs as profoundly pleiotropic.
Pleiotropic,
Right.
meaning multifaceted, right?
Exactly. They don't just pull one lever. They initiate a cascading wave of effects across multiple, totally different cell types. We already discussed the indirect effect. They clone and expand those regulatory T cells.
Right, the peacekeepers.
But they also act directly on the innate immune system, completely bypassing the T cells.
Wait, really? They act directly on the wrecking crew itself.
Yes. They approach the macrophages and the neutrophils, which are the cells causing the acute immediate damage, and physically reprogram them.
Oh, wow.
They shift macrophages from an aggressive inflammatory M1 state into a tissue reparative M2 state.
So they basically walk up to the demolition crew, take away their sledgehammers, and hand them trowels to start rebuilding.
That's exactly what's happened.
And as they rebuild, there was a bonus effect hidden in the data that completely blew my mind. Angiogenesis.
The formation of new blood vessels.
Yeah, the iCDCs actually spurred the growth of entirely new capillary networks within the damaged heart tissue. The paper noted a massive increase in CD31 positive cell density,
which is a key marker for endothelial cells lining new blood vessels.
Think back to our earlier discussion about using an assassin SAR-T cell. An assassin cell absolutely does not build new supply lines.
Oh, it doesn't.
By choosing diplomacy and using these iCDCs, you aren't just halting the spread of the scar, you are actively revascularizing the dying tissue.
It represents a massive paradigm shift. We are moving from merely attempting to halt a disease progression to actively promoting structural regeneration in an organ that notoriously just refuses to regenerate.
Let's do our third recap here to lock this in. So bullet 1. Day 3 is the optimal injection window when the FAP target is highly visible but the scar isn't permanent yet.
Yep.
Bullet 2. iCDCs improve heart pumping and reduce scarring across multiple types of heart failure models.
It's true.
And bullet 3. They work by calming innate immune cells, boosting TREGs, and amazingly, building new blood vessels.
It really is a monumental achievement in a mouse.
Right, in a mouse. But we must acknowledge the limitations of murine models. A mouse heart is the size of a dime and beats up to 600 times a minute.
Yeah, their biology is very different from ours. Over the decades, we have cured mice of countless diseases using therapies that completely failed to translate into human biology.
Exactly. So how do we know a targeted iCDC works in a biological system closer to our own?
Which brings us to the ultimate stress test in the paper. The researchers advanced their study into a primate paradigm, specifically utilizing macaque monkeys.
And why macaques?
The non-human primate model is critical because their cardiac electrophysiology, their immune responses, and the physical architecture of their hearts closely mirror humans.
So they took the monkey's own autologous dendritic cells, engineered them with the FAP-ZIP code and the triple payload, and injected them after a chemically induced myocardial infarction.
Right. And the imaging from this phase was just incredible. They monitored the monkeys using late gadolinium enhancement MRIs, or LGE.
For those unfamiliar with that, gadolinium is a contrast dye injected into the blood. In healthy, pumping heart muscle, the dye washes in and washes right back out.
But in a dense fibrotic scar, the dye gets trapped in the collagen matrix.
So on the MRI, the healthy muscle is dark, and the scar tissue glows a bright, stark white.
It provides a literal real-time map of the damage, and at 3 months post-infarction, the MRIs definitively showed that the monkeys treated with iCDCs had significantly smaller infarct sizes.
Way less glowing white scar tissue.
Exactly. They also demonstrated vastly superior ejection fraction recovery compared to the untreated control group, so the mechanism held up perfectly in a primate.
Okay, efficacy is amazing, but my immediate skepticism always jumps to safety. If we are actively manipulating the immune system, forcing cells to aggregate and release cytokines inside the heart, which is a giant, exquisitely sensitive electrical organ, aren't we risking catastrophic electrical misfires?
It is the most vital question to ask. I mean, an ectopic immune response in the myocardium frequently triggers fetal arrhythmias.
Right.
But the continuous 24/7 Holter ECG data on these animals showed absolute electrical stability.
Wow.
There was zero increased arrhythmogenic risk, no sustained ventricular tachycardia, no dangerous spikes in premature ventricular contractions.
Well, I actually have to push back on another safety claim in the paper, though. They mentioned zero systemic toxicity.
Yeah.
Are we really supposed to believe that injecting millions of engineered, highly potent immune cells into the general bloodstream resulted in zero off-target effects?
Sounds suspiciously perfect, I know. But the logic and the blood work actually backs it up. They monitored liver enzymes, kidney function, and complete blood counts for months. Everything remained at healthy baselines.
How is that possible?
The reason for that pristine safety profile comes right back to the FAP-SCFV-ZIP code. The triple payload, the bouncer, the negotiator, the soothing signals, is largely tethered to the membrane of the iCDC.
Oh, so it isn't just floating freely in the blood.
Exactly. And the iCDC only drops its anchor when it finds the FAP protein. Because FAP is virtually non-existent in healthy resting organs like the liver or lungs, the iCDCs simply bypass them.
Ah, so the immunosuppression is aggressively hyperlocalized.
Right. Which sharply contrasts, again, with cytolytic cell therapies, like CAR-RT, that can sometimes cause systemic cytokine storms when they start indiscriminately killing targets.
iCDCs don't destroy the microenvironment, they reprogram it.
It proves that in highly fragile organs, persuading the neighborhood to heal is profoundly safer and more effective than burning the neighborhood down just to eliminate the bad actors.
It really is an absolute masterclass in bioengineering. We've seen today how heart failure relies on this vicious feedback loop of injury, runaway inflammation, and suffocating scar tissue.
Yep, a deadly loop.
For decades, cardiology has been forced to use systemic wet blankets that compromise the whole patient. But by taking dendritic cells, outfitting them with a FAP-seeking homing beacon, and arming them with a precise triple payload to forcefully negotiate a local ceasefire science, has finally found a way to break that loop.
They rebuild blood vessels, halt the scarring, and leave the rest of the patient's immune system completely untouched. It fundamentally changes our approach to cardiovascular immunology.
It really does. But before we sign off, I want to leave you listening with one final expansive thought to chew on.
What's that?
Well, this entire paper and our entire deep dive today has been hyper-focused on the heart. But FAP expressing fibroblasts and runaway chronic inflammation are not unique to cardiac tissue.
Not at all.
They are the exact biological culprits driving virtually every major fibrotic and autoimmune disease in the human body. From liver cirrhosis to idiopathic pulmonary fibrosis in the lungs to certain forms of chronic kidney disease.
The mechanisms of tissue scarring are largely conserved across all those organs.
Right. So, if we can successfully program ZIP-coded immune peacekeepers to halt fibrosis and negotiate a ceasefire in a beating monkey heart, are we simply looking at a new heart failure drug? Or are we actually looking at the master blueprint for a universal off switch for chronic inflammation everywhere in the human body?
Imagine a future where liver cirrhosis or lung fibrosis isn't a death sentence, but something a targeted dendritic cell can just reverse.
Exactly. It's something to think about. Thank you for joining us on this deep dive. Keep questioning the world around you. Keep looking for the how and the why behind the headlines, and we will catch you next time.